All right, well, welcome everyone. We're quite excited to have you. This is our last Project Echo of 2023 for our community of practice in East Africa. And we're going to be focusing on palliative care in humanitarian settings for the rest of this Project Echo. We'll go and continue into 2024 with quite a good lineup of topics and discussions. And today we're excited to have Ann Kelmen with us. She's based out of the US and she's been one of our faculty members for, I think, over a year, definitely coming up to 2 years, and has been very committed to teaching palliative care in difficult settings, and we're excited that she's with us today. The topic that she'll be focusing on is psychosocial burden of providing care to patients with life-limiting illnesses, especially with a focus on humanitarian settings. And in our area in East Africa, we are focused on supporting patients related to conflict, climate change. Sometimes people have to be internally displaced. We usually have people on the call from a variety of countries in East Africa, including Somalia, South Sudan, Kenya, Sudan, Tanzania, Uganda, Rwanda, and we're really grateful to have this opportunity. So Ann is a director of psychosocial palliative care at a university hospital, at a hospital center in Washington in the US. And we'll give it over to you, Ann, for the teaching for today. After Ann finishes her teaching, we'll go into a short time of discussion. So if you do have any questions about the topic, you can put them in the chat. And then we'll do our case-based discussion as well after that. So thanks a lot, Ann.
Thank you. Thank you for having me. Good afternoon or good morning if you're on the East Coast of the United States like me. I'm going to go ahead and share my screen. Let's see. Okay. All right. Can you see that okay? So here are some learning objectives today. By the end of the session, hope we'll be able to describe the difference between depression and anxiety, explain the concept of sitting with suffering, and understand how to do a basic psychosocial assessment. So when we talk about psychological burden for people who have a serious illness, it can be very common for patients to experience depression, anxiety, demoralization, worry, and fear. And we'll go over each of these more in detail and ways that you can work to kind of treat depression and anxiety, how you can handle demoralization, and explore worries and fears that patients may have. So when we talk about a psychosocial assessment versus a social history, you know, when you're doing a social history with patients, it's really more than tobacco and substance use history. It includes a person and environment perspective. And I just saw this quote from, well, what used to be Twitter. I'm tired of learning who my patients really were by reading their obituaries and attending their funerals. The social history is a reductive, sequence-long assessment of lifestyle risk factors. And it's often a checkbox of vices. It doesn't really tell you anything about, you know, who the individual is. So how can we explore who the individual was before they got sick, how their illness has impacted them, and what they hope for going forward? I really like the question of the dignity therapy question that was developed out of Canada. And it's a simple question of, what do I need to know about you as a person to give you the best care possible? This quote, you know, who is the person in this case? We're often so focused on the diagnosis that we lose the value. We sort of ride over or lose the values of like, what is important to this individual? And another way you could frame this is just, tell me a little bit about yourself as a person. What brings you joy? And there's some questions I have later on another slide to really explore what is valuable to the individual. So when we talk about a psychosocial assessment, here are a couple of questions you can ask. And you can see in this graphic, it really, you know, goes over psychological, social, what is involved in social. It might be family, relationships, psychological coping skills, self-esteem, but you can see how all of these interact with each other. And here's a list of questions that you can ask to further explore. You know, what helps you cope? What are you hoping for? How is your mood? And what brings you joy? There's a difference between depression and demoralization. So when we're talking about depression, there may be an indication for medications to help manage severe depression. If somebody is really feeling hopeless or helpless and doesn't see a path forward. Demoralization, I find, is often more common for people who have a serious illness, where they may be expressing a lot of frustrations that can occur. They might be struggling with pain. They might be struggling with worry about the future. But if you really focus and treat the pain, then the individual feels a little bit better and they're maybe not demoralized. Or maybe they've been in the hospital for a long time, or they've traveled a far away from family to get treatment and they're feeling really isolated and lonely. I would categorize that as more demoralization than depression. Depression is really more when somebody is feeling helpless and has a lack of meaning. So, psychological and emotional support. It's important to manage physical symptoms because you often can't get to emotional processing when someone is in so much physical pain. So first, work to treat the physical pain. Validating emotions is very important. Instead of saying, I know how you feel, try, well, it's common to feel, or I can only imagine how difficult this must be. Being aware of your nonverbal cues, showing, notice your own body language, showing a non-judgmental presence. You can also notice the body language of the patient, and you could comment, you look sad today. Tell me a little bit about what's going on. You can explore, what has worked to help in the past to help you cope. And often then, there may be additional needs to refer to outside counseling if you don't have access to your own mental health providers within your clinical setting. A lot of times faith and spirituality is a very important part of coping. And so integrating whether or not you have a spiritual care leader in your area that can also help, or individuals who have their own spiritual leader that they can meet with to help explore their worries and fears around their diagnosis. So depression and anxiety, I talked a little bit about depression, but persistent low mood, loss of interest in everyday activities, just feelings of hopelessness, worthlessness, or exploring, are you having thoughts of hurting yourself or somebody else? So here's some medications, that may be SSRIs or antidepressants. And it may be that, sometimes they can take a long time, 4 to 6 weeks. And so it may be just during that time reassessing how the individual is feeling. Often with depression, you can explore meaning, and you can explore how did you find meaning before your diagnosis, and how do you continue to find meaning? And if you focus on ways that an individual can continue to find meaning, that may also help in addition to the medications if somebody is experiencing severe depression. Anxiety, provide techniques for relaxation. Sometimes with anxiety, people are often just really going to their head and spiraling. There are medications that can help with that, but there can be a lot of relaxation or grounding techniques. And even in a clinic setting, a simple one is like, let's take a minute to notice where your feet are. Can you feel your feet on the ground? Can you feel your connection to the floor underneath you? You can also do this with a patient in clinic. It's just even putting your hand here for people who are really anxious and maybe their heart starts racing and then they're starting to have more worry. Just even putting your hand kind of over your heart can really help bring some more connection to your body. And then exploring social support. Is somebody isolated and a lack of social support? Really the unit of care being the family, because the illness not only impacts the individual, but the family. So let's say that somebody, was the primary caregiver for the family, and then they got sick and they could no longer work. So then there's an impact on finances, income generation. There can be a lot of then caregiver burden if you have to stop working to be able to care for a family member. And families often need, information. because sometimes what can be the hardest is the not knowing. So explaining, what to expect in the future. This may happen in 2 months. This might happen in 6 months. And then asking the individual, how do you best process information? Is it helpful for you to know everything? Would you like to know what the prognosis may be based on our best estimates? Some people will want to know that and other people won't. And then just practical support, basic nursing care, medication counseling. So spiritual support, and I think on the next slide, there's a spiritual screening we can go through together. Really listening to the person's story and showing compassion. Avoid giving answers or advice, including, what might be imposing your own beliefs. You can use these prompts, tell me more about that. Or it sounds like your faith is really important to you. I would like to know more. What does that feel like for you? And sometimes when you're exploring, what do you hope for going forward? Somebody may say, well, I just want to be better. I want to get better. And exploring, like, how do you know when you feel better? Or what might better look like for you? And sometimes it could be very simple things, like I would just like to be able to have less pain so I can spend time with my family. Avoid false reassurance if the person talks about death or dying. And we're going to talk about the concept of sitting with suffering. Avoid saying, don't worry, it'll be okay. But you can try exploring, like, how is your mood? What are you worried about? And what is helping you cope with all of this? Coping may be found through interactions with family and friends, creative activities like music or art, and support from a religious or spiritual leader. So this article from 2016 talks about the concept of sitting with suffering. So rather trying to, fix or change somebody's mood, acknowledging the deep suffering that comes with illness and death. And so talking about how suffering is very intrinsic, very common at end of life. It's very common for people to have death anxiety. It's very common for people to have a lot of losses, loss of job, loss of income, loss of independence. And with that loss of independence, often patients may feel like they're a burden to their family. Even though their family may be very loving and supporting, it feels sometimes to the individual that, the amount that I'm asking from my family and friends, I feel like I'm a burden and I don't want them to worry about me. Common worry for family, especially if there's young children, like what's going to happen to my children? I'm worried that over time I'm going to require more care and that's going to be too much on my family. And then loneliness, not only just loneliness, maybe if you have to travel to get treatment or being away from your family, but loneliness with the illness itself and feeling like nobody really understands what I'm going through. It feels so lonely to be going through all of these treatments. And then how do you further assess for spiritual distress? This one question can be very helpful. Do you feel at peace? Spiritual well-being can often be understood as a feeling of peace. Spiritual distress can occur when people are unable to find sources of meaning and hope, love, peace, comfort, strength, and connection in their life. And this distress can affect their physical and mental health. And there are many ways that people find meaning, and exploring those sources of meaning can be powerful. Terminal illness can often cause spiritual distress in patients as well as their family and friends. And so this spiritual assessment is the HOPE assessment. So source, and then you can ask, are you part of an organized religion? Do you have a spiritual practice which helps you? And what are the effects on medical care and treatment? You can also use, and I'll put this in the chat when I'm done speaking, the Psychosocial assessment for spirituality, which is faith. Do you come from a particular faith or spiritual tradition that's important to you? The I is, exploring how important that is. The C is, do you have a community, a spiritual community that's important to you? And then the A is, how can we best address this in your care? So just taking a minute to think of this, there's a 45-year-old with metastatic ovarian cancer. She was admitted to the hospital with a small bowel obstruction, and her prognosis is likely weeks. And she has 2 children who are ages 13 and 14. And the nurse reports she's been crying a lot and worries about her children and has asked for help. You could just put in the chat, what might you explore with her? Certainly you could, one thing that I was thinking of is, what is she most worried about? You could explore what she hopes for going forward. And you can, as we kind of go through the next slides, you can think about how you might do a psychosocial assessment with her, maybe exploring sources of meaning in her life. So just to summarize, psychological distress, depression, and anxiety are common for patients facing a life-threatening illness. Palliative care providers support families by giving information, emotional support, practical support. And spiritual distress may impact on physical and mental well-being. Listening and allowing the patient or family member to identify what helps them in difficult times can help. And on the last slide here, I left a couple of prompts. So, instead of saying, I know how you feel, try, I can't imagine how hard this must be, or I can only imagine how hard this must be. Instead of sort of, saying, don't be sad, allowing yourself to like really sit with the suffering of how sad somebody may be. Like, it's okay to cry, and showing a supportive presence. Instead of saying, don't worry, it can be scary to think about dying. And what are you most worried about? And instead of sort of reassuring or saying like, you will find meaning, you can explore like what brings you meaning or what brings you joy. So I'm going to go ahead and stop sharing, and then we'll have some time for discussion and questions that you have. And you're welcome to put anything in the chat.
Thanks, Anne. I think those were actually even just the last slide, some really good reminders of how to engage with someone to help them even just identify and understand how they're feeling. Sometimes patients don't necessarily want to think about these things, yet we also maybe avoid these kinds of more difficult conversations. And I think that as we get more confident and our palliative care skills grow, we will have the ability to kind of ask these and also be able to engage with people in this way.
Mm-hmm.
Does anyone have a question about providing support like this to patients? I know that in many of our settings, we have patients that have that are suffering with these issues. Does anyone have an example or a question related to how to do this well? Is there someone on your team that tends to be the one who is always kind of asked upon to support patients in this way?
I know here in the States, it's usually if we have a social worker on our team or or clinical psychologist or one of our chaplains.
Mm. Yeah, Ali, what do you guys do on your team? I know Ali works in a private clinic now, so he doesn't have as big of a team. But Ali, how do you find that you can support patients if they're dealing with psychological issues or they're feeling depressed or worried?
Yeah, and Erin does. Thank you. Outside, we support patients with home-based care. We normally do home visit and discussing with the family members and the caregivers. And we normally provide family-centered care at the home visit, and at the clinic where we work also, we treat them and do more investigations in order to know the clear and diagnosis of the client, so that we give all supportive treatment. Like if the patient is dehydrated or feeling pain, we normally treat them and with the pain and give supportive treatment. Like when we do home visits, there are some patients who need some pampers or who need sometimes milk, need soap, some essential things. We normally also assist them and visit at the home level. Yeah.
I think it's a really good point of trying to be able to see a patient in their most comfortable setting. Sometimes when they come to the clinic, they may not be comfortable to necessarily share how they're feeling because, you know, they're coming, they're seeing a physician or a doctor or clinical officer or nurse, and it seems very professional. But I think you're right. If we can access home visits, maybe you're seeing someone in their most comfortable setting and they may be more willing to share about how they're feeling. I think it's a really good point also to make sure we think of really practical things to support our patients so that potentially they potentially could have less worries about their physical needs. So then we could attend to some of their emotional needs as well, like supporting them with food. I think it's a good point. Thanks, Ali. All right, Anne or Velma, there's a good question in the chat. How can we notice a child who has psychological distress, and how do you go about it, regardless, I guess, if they're not able to speak? So maybe this would be quite a young child or potentially a nonverbal patient.
I think you can look for the signs of distress. So it could be, you know, if they look like, if their face is sort of, you know, I often sort of look here to see if somebody has distress right here. If there's frequent crying and how you can assess for that. And I think also then exploring with the parents of how do they look to you today? Because sometimes the parents who know the child best may be able to pick up on smaller cues that we're not able to see.
Yeah, especially because a caregiver will be the one that's spending most likely long periods of time with the child. They may know the child really well. Vilma, do you often see patients like this at home? I know you're in the hospice or community-based palliative care.
Yeah, and you know, that's a big concern for parents actually, because if they don't know, they don't even know what's happening, right? And a lot of the times it's just about encouraging parents to have this conversation. It's just that the kids, you know, it's known that when they don't know what's happening, they tend to think and imagine the worst, right? So, and having conversations at their level, asking questions and answering honestly, simple words. But it also can be just activities, right? There's so many things out there that can be used with kids and they can express themselves in other ways, like, you know, drawing pictures or maybe even, you know, if it's the child, you know, if the parent is the one that's ill and they don't understand, they might be just grieving too, you know, not having the parent that used to play with them or things like that. So once we introduce that into, you know, it's a different type of normal, but once we introduce that, kids tend to respond well. But being included, I guess, is just, that's a hard one, right, with kids.
Yeah, I think it's a really interesting thing. I think when you see a child in psychological distress, I think it's very disturbing, even if you're a professional clinician, and especially when a child is nonverbal, it can be really difficult. So I would say definitely reaching out to someone to help you, maybe come up with a plan of how to potentially address it, but very quickly trying to find ways to make the environment comfortable for the child. So if for example, they do have access or it seems like they're in pain, treating the pain, you know, using things like music or massage, things that potentially have worked in the past. I would say if you were a caregiver or potentially a palliative care provider, and you were in a situation where a child seems to be in a lot of distress and you're trying to you know, potentially link it to a psychological issue. I think trying to treat it and address it as quickly as you can as you're trying to assess what are the main causes with some of those things such as music, making sure their caregiver is there, if there's someone that they're very comfortable with, making sure that person is there. Yeah, I think those kinds of things are really important. And then for sure, if those things are really not working and the child is not calming down, I would say bringing them to a facility where you can get some extra support, maybe from a psychologist or, yeah, I think it's tricky, especially for nonverbal children, to maybe potentially fully identify what's causing the distress. We could potentially look, Anne, I don't know if we could maybe after this session look for some resources on that. I'm not so familiar on how to do that for children, but you guys may come across these as patients. So
I do have a lot of resources on how to support children, and there's
okay.
some webinars, free webinars too,
Yeah.
about that I can share the links with you. So
Okay.
I can. One thing that I was gonna say, and I'm gonna show you, like we do like tangible things. So these are comfort birds for children. I don't know if you can see them.
Yeah.
So it is like, you know, it's a wooden bird, and we have a volunteer that carves this, you know, herself. And we put together little things like that the kids can have as a reminder, right? Like you're saying, we talk about that. So little things that maybe they can touch, feel, and it helps them process what's happening if you have access to that. But it can be anything. It can be a stuffed animal, it can be a blanket, it can be you know, the hogs that we draw on like a piece of you know, like a piece of, you know, fabric, and then they can put them around them and things like that. That it, you know, they can relate to something. I'll send you the resources.
Yeah. Yeah, it's a really good point. Finding things that can give the child comfort, something that a parent or the caregiver could kind of get easily.
I think like you said, massage, but you know, I think touch is important too. So if a nonverbal child is very distressed, even just like placing a hand or like holding their hand can help with regulation too.
Yeah, Rama had some good suggestions. If you do see someone crying, asking the parent or the caregiver how they see the child, or asking the child to potentially draw how they're feeling. I think for sure those things are really good to engage with the patient as much as you can, to make sure the family is actively involved in the care and coming up with solutions, because they'll know the patient the best. Yeah. Well, thanks everyone. Anne, I think you had mentioned you might put the FICA assessment into the chat. Can you do that? I know that many of the patients that we're seeing in our settings often have really strong religious and spiritual kind of desires and wishes. Oftentimes that's one of the things that they really rely on. And I think if we can become good at assessing and supporting them in that, that will also lead to really good holistic care for patients and families. Well, thank you, Anne. Thanks so much. Anne is going to be with us for another 20 minutes or so. So if you have any specific questions, again, related to the burden that oftentimes we see that patients experience and we try to address, please put a question in the chat. I know a few people came in throughout the lecture, but no problem. She's with us for a little bit longer. We'll now shift to our case discussion. So we had a really interesting case this month, and I was really honored actually to work very closely with the presenter. Unfortunately, today he had to leave the camp where he works, the refugee camp where he works, to assist a patient and transport them to another facility. So he isn't able to be with us live. So actually yesterday, the presenter and myself recorded the case presentation. So I would love to play that right now. And then we will have a time of discussion afterwards. We'll probably go on the call till about 15 or 20 after the hour if you guys have time to stay on with us. His case presentation was about 20 minutes. So let me share the information. The connection wasn't great, but hopefully I'll be able to fill in the details after. So I will introduce him to you. His name is Osman, and he is a humanitarian nurse with the Kenya Red Cross in Dadaab refugee camp.
Key question for the case presentation is, we can help the patient to know how to seek appropriate care by clearly explaining her situation to her and to her family so that she can decide what is best for her. And we need to build a trusting relationship with the patient so that she and her family are comfortable to allow our advice. So the patient details, go to the next page. Patient details is age 13 years, diagnosed and date. Is RHD child, was diagnosed at 2 years on 2/13. Gender, she's a female. Other diagnosis, RHF. And okay, patient details. Age is total for 13 years, gender is female, diagnosis and date. Yeah, on 23rd of 2023, October. But it's through to APCA hospital that the patient was taken and she was diagnosed as transposition of the great arteries, including aortic arc interruption with pulmonary artery, PGA continuous as the descended aorta, cardiac catheterization diagnosed in Nairobi. Other diagnosis, complex diagnosis leading to major cardiac issues and poor prognosis. Okay, treatment and significant investigations. Patient was referred from the Dadaab refugee complex to Aga Khan Hospital, Nairobi, October 2, 2023. Severely ill-looking catheteric profound lethargy, central and peripheral cyanosis. No pallor, no jaundice, no edema, oral thrush. 21 kg, that's a kg. Height is 131 centimeter. PP 99/57. Heart rate 128 per minute. HP is 12.6. Respiratory chest, deformity, bilateral, and adequate air entry. And I think that the respiratory rate is 19 per minute. CNS allowed yet lethargy, reduce motor muscle bulk. Can go to the next page. And retreatment and significant investigation, referral from the Dadaab Refugee Complex to Aga Khan Hospital, Nairobi, October 2023. Discharge after cardiac procedure for accurate diagnosis with LASIX 40 milligram daily for 15 months. Then reassess. Aldoten 12.5 milligram daily for 15 months. Then reassess. Periodic trips follow-up from team at Aga Khan. Prognosis is poor. And just wait. Just wait, yeah. A referral from the Dadaab Refugee Complex, Aga Khan, Nairobi, discharge after cardiac procedure for accurate diagnosis with LASIX 40 milligram for 50 months, then recess, Aldoten 12.5 milligram daily for 50 months, periodic for follow-up for the team Aga Khan. Patient will experience what do you call it? Serious dyspnea. Then needs. I'm not seeing very well here. Yeah. Patient will experience exertional dyspnea, needs to remain calm, limited activities and exertion, cannot get pregnant for herself and baby, as she will not be able to manage a pregnancy. Currently not fit for surgery. Strong psychosocial support needed to encourage as normal as life is. She's able to encourage. She's able to normal as she is able to go to continue encourage to continue with the school. Next page. Other investigations, treatment and significant investigations. Other investigations, positive throat culture for group beta hemolytic streptococci, elevated and erythrocytes sedimentation rate. C, reactive protein, leukocytosis, chest X-ray, mild to moderate, cardiomegaly with enlarged right atrium, right ventricle, prominent pulmonary artery segment, increased pulmonary vascular markings. ECG right axis right ventricular lead D1 was signs of left right shunt flow. Next page. Treatment and significant non-pharmacological patients to maintain proper position using hands, which is breathing exercise, play activity for children age. assessment brief sections, including relevant treatments. The patient experience difficulty breathing, dyspnea, and breathing experience with the changing the patient to position and ask her to do breathing in resting positions. Normally, the patient compasses, has poor appetite, doesn't sleep very well, insomnia, chest inflammation, fever. The child has not gone to school for almost 3 months due to she convulses. She's not. She's
No.
And Osman, does she take any medication for the seizures currently? Do you know?
no, normally now previously she used to take bedtime penicillin or 1.2, but nowadays she takes Aldactin and Lactis.
Yeah.
But normally we give her oxygen when she comes to the hospital when she has difficulty in breathing.
Yeah. Okay, to the next one.
Again, a child also looks like age and physical appearance is not equal. Holistic assessment brief, psychological concern, comprehensive evaluation of patient emotional and social well-being to alleviate suffering, patient and family receiving counseling sessions regarding the condition of the patient and continued treatment.
So there was just a few questions from the other faculty members, just wondering who assessed her psychosocial? Have you guys been able to talk to her about her emotions and how she's feeling?
So socially, the family is being assessed by our mentor team.
Yeah.
We took a review, and normally the family are very much worried of the health of the child.
Yeah.
Since almost 13 years, they have been struggling to get treatment for the child, but which is not whatever they're getting is not helpful, and they are very much worried.
Yeah.
And in our hand, they were told that the child will have a surgical intervention of which high risk, of which our hand are not yet done, and the families are at least very much worried.
Mm-hmm.
Years ago, when I approached them, they said that if surgical intervention cannot be done in Nairobi,
Yeah.
why don't we look for them for resettlement in abroad? If maybe there they can get better doctors who can intervene their problem. Again, here with just and hot weather,
Yeah.
the child is not suitable is not conducive for this weather.
Yeah.
Yeah, because of congestion of the heart and chest. Normally with the dust, she gets a lot of allergy with a sunny hot sun.
Yeah.
So the family are very much worried, but we gave them reassurance. We tell them that this is they have to persevere with the illness.
Yeah.
And as we pursue, we can later we can take them back to Khan for reassessment, and if in case they say the doctors say that they will intervene and do the surgical,
Yeah.
that's what we shall see it. But for the time being, we are giving them psychosocial support with our mentor team, and also we give them their MOs. Our MOs are reviewing them sometimes when the child becomes very serious ill.
Yeah. And has anyone had a chance to ask the girl how she's feeling? Does she also feel worried?
I had the chance 2 days ago when I was telling you that let me get in touch with the child and the family.
Yeah.
Yeah, the child normally when she sleeps, she doesn't sleep very well, but
Okay.
even when she sleeps, there there's a snoring, chest in
Yeah.
drawing. You think that if it's a lion that is roaring, eh?
Yeah.
Yeah, so she looks physically, down, eh? Physical appearance is not, and her age has not proportion, eh?
Yeah.
She very tiny. At the age of 13, there's an undergrowth weight.
Mm.
Are you getting my point?
Yeah. Yeah.
So yeah, she feeds, but poor appetite. She has normally for the 3 months since she came back from where she doesn't go to school. The family told me
Yeah.
that she convulses, and normally when she convulses, we bring her back, we bring her to the hospital. Then we assist her with putting on oxygen and in a other treatment that will assist her to relieve her.
Yeah. Okay, let's go to the next
So,
slide.
okay. Yeah, holistic assessment, brief, family concerns, dynamic, mother and father they live in the Dab refugee complex as primary caregivers. Fifth born of 9 children ranging from 6 years old to 2 years old. Family concern about long-term impact of the disease prognosis, socioeconomic constraints, and long-term treatment leading to family to mental issues like depression, fatigue, and lose hope in the care of the patient. Family is trying to cope with treatment of the patient since the patient was diagnosed in childhood, stayed with the condition for quite long. Family adapted treatment modality as they are able, and yet the patient has recurrent heart symptoms.
So it does sound like the patient and the family has been trying to access a variety of options for the child. It seems like they're trying to do their best to give her the best care.
Yeah, the family are trying to care about the child,
Yeah.
coming periodically or every 2 weeks to the hospital
Yeah.
to seek health assistance in our center.
Yeah.
Normally, they see that there is no, with the spiritually, they tried with the sheikhs to read for them the
Yeah.
but there's no recovery. But the only hope that they have is the medical through the hospital.
Yeah.
A holistic assessment, brief condition. Holistic assessment, brief spiritual concerns, providing supportive, feel more comfortable staying within the family members and enjoying the congregation. Yeah, that's what they do normally. Yeah.
Yeah. So
Yes.
just going back to communication, do you think that the family understands that she might not live until she's an adult? Do you think they may understand that she might have a short life because of her heart condition?
Yes, and even them, they witness that the child is not according to their health status.
Yeah.
They are understanding. But one thing, since from 2 years up to now,
Yeah.
when they see that it is taking, it's maybe the day her day is not yet, but it's almost 13 years.
Yeah.
The child is living with the disease, and there's no.
Yeah. I'll just stop it there. I think that hopefully you guys are still with me. Hopefully you got a good understanding of the case. Let me quickly share the last summary. I'm sorry, the connection was not great for Osman, but he was working really hard all month to put together the presentation. So I did want to give him a chance to share it. So let me just share with you the summary of the situation, and then hopefully we can have a good discussion about her case. So the last slide I'll share is just a summary of the patient. So can you see the screen? So the case involves the 13-year-old girl, female patient. She was diagnosed with a complex cardiac diagnosis related to the transposition of her great arteries from birth. Originally, she was treated in the camp, as Osman had said, for rheumatic fever and rheumatic heart disease, yet it was a misdiagnosis and she hadn't been treated correctly for most of her life. It was when the Aga Khan team and the cardiologist, the specialist came, that they were able to identify that she actually had a congenital heart defect. A holistic assessment was done in the camp, which included pain management, her psychosocial considerations, as well as supporting her family and trying to implement some communication strategies, as well as supporting her spiritually. Currently, the team that's part of the partnership is the Aga Khan team that does cardiology support and a reverse referral, as well as the Kenya Red Cross and International Rescue Committee. I think on the call today is one of the clinical officers with IRC who helps manage the project. And a comprehensive approach aims to provide the tailored and effective care for this young patient who also has some serious respiratory symptoms. She's being followed up in Dadaab with Kenya Red Cross as well as IRC. And we're hoping in the future that she'll have access to some home visits for her support. So I'll just stop sharing there. I'll put the questions in the chat, but I'm just curious to hear what people's initial thoughts on this case are. I know a few people had to leave, but let me put the questions in the chat. The team at the Red Cross were wondering if the group could help identify some of these questions here. So how can we help a patient to know how to seek appropriate care by clearly explaining her situation? How can we support a patient so she can decide what's best, because now she's getting older? What's the best way to build a trusting relationship? And what role does palliative care have related to cardiac conditions? You're welcome to just unmute if you wanted to comment on the case, or if you have any other questions.
Yeah. Good afternoon once again.
Yeah.
Erin, my question goes to Osman.
Yeah.
I want to ask him about in the holistic assessment. Osman said about the family, long-time treatment. They are having issues like mental issues like depressions. The family were not told about the prognosis, or the family were not told about the case of the child, the long-term treatment, were not advised that this is a palliative case. So let me know about that issue of mental issue or like depressions. Looks like the family were not told clear about the case, the long-term treatment.
Yeah, I think it's a complicated case because she was being treated for one illness based on what the team in the camp knew. To the best of their ability, they were treating her for rheumatic heart disease. And then when she wasn't really improving, when the long-term prognosis wasn't great, But then when she did have access to the cardiologist, the assessment, the team in IRC was able to get her connected with the Aga Khan team. And it wasn't until she came into Nairobi that she got a proper diagnosis. So I think some of the depression that her parents experienced was most likely related to the chronic condition she had, that she wasn't improving. Her quality of life was very poor. She wasn't growing. And I think these are probably natural responses to a child that, like a parent feeling very sad about what's happening to their own child. So I can actually follow up with the Red Cross team, though, to see if the family was getting support for those experiences. I don't know if the family had been referred for extra support. Because of course, it sounds like they have a lot of responsibilities. They have 9 children in their family and also a very, very sick child. I would assume that they probably need some extra support, maybe access to a mental health counselor, something like that, to talk about how they're doing, because it potentially could affect the other children, right? In a situation where you have to take care of a very sick child like this, you may not be able to think and provide the same type of care to all of your other children. Michael, Michael Wambua is the clinical officer with IRC who had been also supporting the case. And I see Annalise is also on the call. Michael, do you have any comments? Do you know what IRC was doing or what access the team might be able to do even going forward for the parents?
Yes, hello. You can hear me?
Yeah, go ahead. Yes, go ahead.
Yes, at least I've managed to join. And as we had discussed in the morning, it's a child we have not very much interacted, but just from the history and the previous history which we got when the child was first brought to RC, we think that we may need to interact, like come together and see, okay, like what is happening down at the Red Cross, what they are doing. Then we see whether there's anything else more we can add on that. And especially also giving the psychosocial support, because the situation is complex, because considering that there's the PDA, this one they have called the Ductus arteriosus, that is a pulmonary artery joining together with the aorta. So this is a child who is not likely to enjoy life with the other children of our age. And for the short time I interacted with the child, is a child who looked miserable, not very interacting, who feels like left out alone, like wondering what happened to myself. So it's true that we need like to collaborate with the other team on the other side. We have visits and give some encouragement to the family, and also to reassure them that yes, it's a child who is very sick, whose condition has passed the time of intervention, as it was described by the cardiologist and the other specialist. So when you get back, maybe most of us maybe we are on leave. When you get back, maybe we can team up with a group from Red Cross and maybe make an assessment and see what we can be able to, how we can be able to assist them.
Yeah, I think it's a really good idea, especially because of the current situation that the child may continue to have. Osman was saying she occasionally has seizures and it's quite stressful. I feel like the child and the family actually probably need quite a bit of support, especially also because she's not a candidate for surgery. So I think it would be great if, and I'm happy to help the team kind of think up some, like a plan of care for her, and have some extra supports around her and her parents, because it sounds like it's a very challenging case, and could be very difficult for the parents too.
Okay. Hi, Erin.
Yeah.
Maybe one more thing about the seizures. It's maybe something we do not factor in when doing the cardiology evaluation.
Yeah,
Maybe now we can also get back and also involve a neurologist to review the child
yeah,
and probably do an EEG, which might help us to understand whether these seizures are connected to the heart problem or
yeah.
is originating another problem.
Another cause,
Because with
yeah.
the seizures, again with the heart complications, then that one combined may be more complicated.
Hmm.
Maybe that's something we'll take up in early next month
Yeah,
and try to engage neurologists to review and probably do the necessary investigations and be able to see how best you can manage these issues.
hmm. Yeah, I spoke to Dr. Shan, who's the cardiologist from Aga Khan, who initially saw the patient and did the specialist visit, and he did say that the seizures often are caused due to low oxygen level of the patient. So it does sound like the family, when they happen, they do tend to take her to a facility where she can access oxygen. So that's positive. But yeah, we should follow up when the teams are back together and come up with some supports and recommendations for the family for sure. Aiden had a good comment in the chat, just that patients can be helped with readiness, providing accurate information, counseling, health education. This is really important, and immediate referral in case the patient continues to get sick. So I think it's really important that we need to find ways to make sure the family is confident when they're at home, that they know what to do and what to be ready for, but also to encourage them to seek out support, maybe in a facility. It sounds like the child is quite ill and probably will be, depending on the family's wish and the patient too, probably she will need some extra support from the facility. Yeah, does anyone have any other comments or questions about the case? We'll just start to wrap up the session for today. I know, Annalise, you joined us a little bit late, but thank you for joining. I know you're really busy at the moment. Nice to see you with us, Annalise. Does anyone have any thoughts on the fact that the child's getting older and how we would include a child? And you can also inform me, for those that are working in Dadaab with more Somali refugees, how do you engage with children as they get older? And when does she begin to be seen more as an adult? I don't know when those kinds of transitions occur. Ali, would you consider a girl her age, as she's getting older, would she be able to make some decisions, or generally is still the parents? Hey, Ali, are you there?
Hi, Erin.
What would you say for a child her age? When does she become a little bit more independent, or she might not ever because she's so sick? Would she be able to tell her mom what she wants to do, or is it more the family making decisions about her care?
You said what is the age of the child?
13.
Yeah, and depending on the family, and the child has right to speak, but the parent have the right to say something.
Mm-hmm.
So the child has rights to say something, but the decision lies with the parents.
Mm-hmm.
To make also a comment on this case about the Dadaab refugee campus referral is the most problem, the referral pathway for such cases. So there's a delay of referral and transportation. So my advice for international organizations about the referral and the communication with the DRS, sometimes you communicate to UNHCR about the referral for the international agencies. For somebody, they wanted to refer to Nairobi, they're saying that there's still delay about the referral. Maybe patient could stay for 2 days, 1 day, 3 days. So the challenge is the referral. So the earlier, the better. The earlier you refer patients, and the better they meet with the doctor as early as they can. So I could advise the international organizations they communicate with the UNHCR about when they have inter-agency meeting, so they make it easier for the referrals for the patients. Thank you.
Yeah, it's interesting in this case, because she was part of the group that got the special referral for the cardiology team. And probably you're right, Ali, if she had been referred even, I don't know, because I'm not a cardiologist, but if she had been referred earlier, I do wonder what her access to surgery would have been. It was very clear, though, despite the referral, her access to curative surgery, she's not fit for that. So although she did have access to referral, these are the cases that we need to continue to find ways to support, because she is, in that sense, more for supportive and palliative care than curative or surgical treatment. Although the team and the cardiology team has offered to continue to see her and do follow-ups and continue to support her. It seemed like it was quite clear that she wasn't going to be able to access surgery, not necessarily because of the resources, but because of her current situation and her ability to be able to manage a surgery. But it's a very complex situation. I mean, she was having symptoms when she was very young. She was very little. And at that point, if she had access to referral, I don't know if it would have been a different situation. I know the Aga Khan team has been able to do, I think, 7 or 8 procedures for children. So this might be something that we'll come across. We'll find ways to engage with them as a team and find better ways to support the patients and families. Well, I think we'll probably end there for today. Thank you, everyone, for joining us. I know this is the last one of the year, but thank you for being committed to learning and engaging. I do hope you all have a really good holiday. Our next teaching session will be in January. And if you are interested, in presenting a case from your team, if you're working in a humanitarian setting and you would like to present, please do let us know. We are always eager to have people engage and share about different things that are happening. And oftentimes it does really lead to good teamwork. So I'm just going to put the date in the chat. Our next one is on January 16th, Tuesday, and it will be at the same time at 3 o'clock. So we hope that you will all be able to join us. And happy holidays, everyone, and have a great new year. We'll see you in 2024. Bye, everyone. Thanks, Ali. Thanks,
Okay,
Michael.
bye. Okay.
Bye.
Bye-bye. Thanks for joining us.